Everyone, Ike Ahmed here from Toronto and Salt Lake City. I'm happy to speak to some technologies from iCare, specifically the Compass visual field. We've had experience with this for the last almost decade, and also our experience with iCare Home. And so it's a pleasure to be talking about technology. I'm a glaucoma specialist, and we've seen a plethora of technologies that have helped improve our precision and diagnostic confidence in practice. You know, one of the problems with visual fields, which is our mainstay in glaucoma, is the challenge of assessing for progression. And because of the retest variability, we need to do a high number of visual fields over a period of time to detect progression. That's inherent with the visual field. And so what can we do to reduce some of this variability that will hopefully be able to allow us to detect progression at an earlier stage? We've seen, for example, that variability results in a delay of progression analysis and a delay of detection of glaucoma. Because, of course, if we're not certain that we're measuring the right points in time, then this results in a lack of ability to be sure of a diagnosis. Compass is a very novel way of looking at visual fields. We're familiar with fundus autoperimetry, for example, with microperimetry, where this is real-time retinal tracking with the confocal disc imaging, allowing the device to actually send stimulus to the exact retinal foci, as opposed to having patients look at that stimulus or look at a fixation target. And so this basically combines scanning ophthalmoscopy with automated perimetry, and to me, it really takes perimetry from where it needs to go. The device is very much like a fundus camera appearance, very intuitive to use for patients. And the nice thing with this device is we don't necessarily need to have refractive lenses or trial lenses, because we're not refracting light into the eye. We're actually projecting light into the eye, into the fundus, to basically track it. And the real key to this is the tracking system. So despite having fixation loss of the patient movement, the device is able to track the retina and project the stimulus exactly on the retina where it needs to go, as opposed to relying on patient fixation, which then basically depends on how accurate the fixation is in terms of where the retinal test location is held. And so, for example, the patient moves. In a standard automated perimetry, that's going to be potentially a fixation loss. But here, even though there may be movement, that target is basically still met because the target is moved with that patient movement. So it's a very compensatory mechanism. Here's a patient that has pretty stable fixation, and you can see, fairly stable fixation, even better on a compass. But here you'll see such highly unstable fixation, and by tracking, we're able to again still maintain fairly accurate,
retina look eye tracking. And that really is a big difference between
what we were seeing. The device is actually able to measure fixation and show us the differences. One of the nice things as well is this is a beautiful confocal imaging device showing true color images of the retina and of the optic nerve. I'm one to always feel that it's important to document the nerve, document the retina, and it's an added feature on the device, which is great. We have infrared, color, and red-free that we can use, of course, for different aspects of retina evaluation, as well as looking for dystrophy and other advantages of red-free light. Now with the Smart Mosaic feature, we can get a fairly good wide field view, and you can see the explicit detail on the imaging. So this device not only does classic and now retinal tracking visual field, but also fundus photography and also wide field photography nicely as well. Just like other platforms, there's a testing strategy with the Compass, and this is basically called ZEST, as that's fast. It's very quick and very fast. We've done a lot of comparison between gold standard Humphrey and Compass, and we find the Compass to be very fast within the time we would expect. This is a standard printout. You can see actually, the fundus imaging here, the color fundus picture of the nerve, and these are all the retinal local that are with their retinal sensitivities. The standard grayscale, total deviation, pattern deviation, we're familiar with this. And then the cluster mean deviation, which I like to see this, which basically shows the hemifield differences between the superior and inferior hemifields, which we know is sensitive in glaucoma. This is the fixation area to track, and this is, again, that posterior pole. So, fairly standard printout, mean deviation, pattern deviation, false negatives, false positives. One thing you don't have to worry about, again, is retinal tracking. Because of a reduction of fixation losses. Of course, the question we often ask ourselves is, how does this compare to gold standard? How does this compare to Humphrey Field Analyzer? Because that is really our gold standard. This is a nice study that was published from an Italian group showing quite good levels of agreement, quite good correlation between mean deviation, mean sensitivity on the Humphrey field analyzer and the compass perimetry. So we can be fairly confident that the correlation between what we measure on the compass is fairly consistent with the Humphrey field analyzer, albeit also with the advantage of having retinal tracking. Any visual field device has to, of course, have robust progression analysis. This is something I've seen evolve with Compass platform. This is called the Smart Progression Analysis, and we can just review the printout here. Basically, basically we're looking at variety of event-based and trend-based analysis, the classical ways to look at visual field progression, and showing the different ways to assess the visual field. Here we're seeing the baseline visual fields, the color, the grayscale pattern deviation, and then the global indices. We also have our last follow-up as well, and this shows us our visual field change. Progression analysis, of course, is where it's all at. We see a nice linear regression showing the mean deviation, very similar to what we see in other standard printouts as well. This gives us more of a trend-based analysis, the rate of progression, and then we see some nice progression event-based analysis comparisons, looking at point-wise, looking at clusters, and looking at time over change. So this a very robust way to assess based on both trend and event-based analysis. I would say this really is very consistent and up to par, if not even more, what we would see with the gold standard of perimetry. And so just again, what we see there is just some more magnified views of this. A very intuitive printout to look at progression analysis, both again, global indices, linear regression, as well as event-based changes and clusters as well. So, it is hard to become a new standard in perimetry because we've had standard perimetry for a long time. I think that this has improved retest reliability. And by doing that, it's improved our confidence when there's a change. Is it change because of a retest variability, or is it true change where actually it's progression? I think this allows us to have confidence in looking at progression, hopefully reduce that number of visits we need to get confidence in looking at progression. So we've had experience with Compass now, I want to say probably over a decade. And for me, it's been our go-to perimeter. I want to switch gears a little bit and talk a bit about another technology which we've adopted in the last 10 years as well. And I'm going to say both these technologies I feel are still in early adoption. I try to be ahead of the curve sometimes I'm not. But I feel that IOP is one area that we really have fallen behind with. We're measuring IOP one time point through a patient's 6-month inter-visit period, and it's just not enough. And why do we need to measure more than one IOP time point? There are patients who are progressing despite a normal pressure, what we think is normal pressure. Patients why we can't explain why they have glaucoma. What is their peak pressure? And these are all things that we can measure now by looking at home tonometry. We know that IOP fluctuates. We know that in glaucoma, the most dangerous time for the optic nerve is when the IOP peaks above a certain target. But yet we measure one time point in an office. And I think that the ability to take pressure measurements over a 24-hour period in a patient's natural habitat, at home, at work, with activity, waking up in the middle of the night as needed to do that, allows us to do it. This is based on rebound tonometry. Rebound tonometry, we know, is probably our best correlate to Goldman. There's some differences in terms of measuring a little higher normal pressures, and at the extreme ranges, there's obviously some variability, but quite accurate correlation to Goldman. Good level of agreement to Goldman. The other nice thing about it is very patient-friendly. So those of you who have tried rebound know that basically it doesn't require anesthesia. The rebound tonometer basically accelerates at a very quick pace to the cornea, and the amount of deceleration basically measures the pressure in the eye. So this is done by a patient at home. It's very intuitive. The instructions are quite followable, and we typically train our patients over a short period of time to basically understand how to do it. And when they do it, they basically measure their IOP over a 1 week period, and we try to get them to do 6 pressure measurements on a day, and at least 1 or 2 overnight as they can. And we see some very interesting findings that really open our eyes and to say, wow, what are we missing? We're just getting a tip of the iceberg of some of our patients. This is an example of a patient where you can see the patient ranges here from down to like 10 millimeters of mercury to 30. That's a massive range. Now, don't get into the absolute number, because what's more important is to look at the variability and that how much we're changing. Of course, there is some correlation to Goldman, but I look at more that variability. And we actually have an ability to see patients when they're measuring it. Before drops, after drops, before activity, after activity. We tell patients to do basically this measurement throughout their whole life as much as they can during that week. Here's a patient who's a 60-year-old patient, mild pigment-dispersing glaucoma. The patient seems to be progressing on OCT. We're not sure. The problem with glaucoma, how often do we say we're not sure? Let's come back for another visit. We're not sure. Let's do something else. Let's measure something else. In-office pressures were 15 to 20, not bad. But when we had the patient do iCare home, we saw some, incredible findings. First of all, a difference between the eyes. Left eye in red, right eye in blue. Look at the massive fluctuation in pressure at different times and consistently over every day. I look at that consistency to show me a pattern, and the pattern here is showing pressure spikes into the 30s and 40s. I mean, this was certainly a clincher for us that we need to do something for this patient. And you can see again those peak IOPs, and that's typically what I look at here. This patient has angle closure, mild glaucoma, pressures were controlled, and you can see consistent pressure elevations in the mornings. And in the office, they were 14 or 15. Well, we're missing that. We're not seeing that when we only measure our pressure in the office. But this gave us a lot of insight into what's happening to this patient 24 hours, and when they're not in the office, when not running. And it allows us to intervene appropriately and early when we have to, and not wait for this to have visual field damage or optic nerve damage. This is a patient with SLT, and they were unstable. Their pressures in the office actually ended up being pretty similar pre and post SLT. And we have a study that we're presenting on this with iCare Home and SLT. And what you can see is before SLT, after SLT, look at the difference in the IOP. The mean may be the same, but the peaks are different. And we have to change our language when it comes to glaucoma to think about peak IOPs, because that's where the damage happens. It's not the average, it's the peaks when this occurs, and that's what we try to look at. And here's some examples again. A patient who had no surgery and had surgery in another example, and you can see that pre and before two different visits, not much difference. With surgery, we see a nice difference in the diurnal fluctuation. So really a nice thing we look at after surgery to validate our surgical success, not just by looking at a single IOP. I'll present one more case to finish this off. This was a young patient, South Asian, who had recent progression in the right eye. They had, and I'm going to say in quote, no pressure glaucoma measured, and with a maximum pressure of 18. Thinnest corneas, pressures were 12 and 11, previous SLT. But they were progressing. Here's the compass visual fields, and you can see the obvious progression in these two visits and other visits as well. And you can see on the OCT, the significant RNFL loss and the RNFL progression as well. So what's going on here? Why is the patient having progression on fields, and why they're getting worse on imaging? The pressures are 12 and 11. We did iCare home on this patient, and you can see the progression just to show that again. And look at this, consistently pressure elevations in both eyes here, and particularly in the right eye, the one that was progressing. This again gave us that validation that we now know what's happening here. This patient doesn't need a pressure of 6. This patient needs a pressure of 12 or 10, 24 hours a day. So we don't necessarily need to do something overly aggressive, maybe something like a microinvasive bleb surgery rather than a trabeculectomy. And that's what we did for this patient, and it probably saved them from having a trab that they probably didn't need. So hopefully I've just shared with you in the last few minutes, some technology that we've really adopted into our practices. I think in glaucoma and all of medicine, it's all about having higher precision, higher sensitivity, higher specificity, right? That's what life is about. How can we be more confident with decisions we make? And by using retinal tracking, by assessing IOP 24 hours a day, I think we have more confidence in making our treatment decisions, and the synergy between all of these interplay into making that decision there. And I'm very excited, by the way, where AI is going with this. Because now with all of this data inputting here over many visits and at home and on visual field parameters and imaging parameters and other demographics, we'll hopefully be able to be at the point where we have greater confidence in making these treatment decisions. I hope that was helpful in sharing some thoughts about both of these innovative glaucoma products. Thank you very much. Thank you.